Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I want to talk a little bit about a new patient that got me thinking about another topic, which is reciprocal inhibition. So my 90-something-year-old drop foot patient is a new patient of mine. Apparently he had sciatica about a year ago, left him with a drop foot. He recovered from the sciatica via physical therapy. And so his son brought him in, and he's great. I mean, I hope that at that age that I am as lucid and fit as this man. He hasn't been able to do much cycling because of the drop foot, but before his sciatica, he was very physically active, a lot of cycling and other things. And he's like mentally completely lucid and speaks very eloquently and without, probably, I probably pause more than he does. He's really not looking like his age. However, he has a drop foot, and so I gave him the upfront warning that everybody's different and everybody doesn't respond the same way. And not all drop foot is the same, and the chronicity matters, and the fact that it's about a little over a year, we have to wait and see. I recommend that we treat at least 3 to 5 times to see if we're going to get the best results. However, I also told him it's not uncommon that someone feels some improvement after the first treatment, because we could often get some firing of the muscles that do dorsiflexion. And the main ones that I focus on the very first visit, because I don't get into the little extensors of the toes and the little extensor, like the peroneus tertius on the first visit. I really want to hit the big guns, the tibialis anterior, the extensor digitorum longus, the extensor hallucis longus, and the peroneals. So that's what I focus on. And I did some electric stim first at 1 hertz for about 10 minutes. And then I changed it to a discontinuous 30 hertz, so that it would contract for 3 seconds at 30 hertz and then relax. And I put it at a comfortable level. And we were getting really good response from his muscles. All the muscles that I was treating. I didn't see much extension of the extensor hallucis longus, but I'm not too worried about that, because since it is inhibited, I wasn't really too worried about getting the exact location for that one. I just want to get into the muscle, and going forward, as we see better improvements, I will get a lot pickier about my motor point location on the big toe. But we were seeing really good movement. And by the way, so I did muscle testing before just to get a baseline, and his tibialis anterior was actually functioning. So he was actually able to lift his foot a bit. He just couldn't move his toes. He couldn't lift his toes, could not evert at all. But he doesn't have much atrophy, so I'm hopeful, we're going to get some good results. And in fact, after treatment, I did do a nerve trunk stimulation for the deep peroneal nerve as well. And he was able to start lifting his toes, and he was everting a bit when he would dorsiflex. So, and his son was remarking at it, because I think his son has been on top of this the whole time and working. He's still getting physical therapy 3 times a week. So so I'm feeling pretty optimistic for him. One thing I noticed in the initial exam was his lack of passive dorsiflexion. His soleus, gastrocs, tibialis posterior, flexor, digitorum longus, all those muscles are very tight. And, on a 90-year-old, I kind of expect that as a normal anyway. And I decided to spend our time first on the front of his leg. Let's get a sense of how much we can wake this up. But my feelings are that because of reciprocal inhibition, the extreme tension in the plantar flexors will reciprocally inhibit his ability to dorsiflex and lift his foot off the floor. So I really can't leave those muscles that tight and hope for the best results possible. So coming up this week when I see him, we're going to start with him prone so that I can treat gastrocs and soleus first, and then we'll end with a very similar treatment to what I did this week. So I was thinking about reciprocal inhibition, and it's something that Vladimir Yanda would talk about a lot. It was, I guess, first, discovered or explained by Sherrington in the early 20th century. I think around 1913 he published his findings. And I think that some people, there's always people who want to make a name for themselves by, contradicting what people have been seeing clinically for a long time, and so there are people who don't believe in reciprocal inhibition, but for the rest of the world of science, it is a thing. And I was looking recently at a paper, and I brought this up so I could tell you the name of the journal. The journal is the Journal of Neurophysiology, volume 119, published in May 2018. And the research article is called Reciprocal Inhibition Between Motor Neurons of the Tibialis Anterior and Triceps surae in Humans. So triceps surae is the gastrocs and soleus as a group that plantar flex. So their test subjects they used surface EMG, and they did isometric contractions, and then the strength was recorded so that they could first stimulate the tibial nerve trunk, and then the other would be the deep peroneal nerve trunk, and they would be doing isometric holds to basically record how much reciprocal inhibition there was when the antagonist is being stimulated. So, and a short type muscle, even if it's not being used, is still able to reciprocally inhibit the agonist. So you don't have to be using the muscle for it to be inhibited. And for people who are new to this terminology, the brief explanation that you typically will see will talk about triceps and biceps. So the body, the spinal segment, can inhibit the antagonist group so that it will relax. So basically, when you use your biceps to lift something or do a curl at the gym, the triceps need to completely shut off and relax and stretch. So that's reciprocal inhibition, and it's done at the spinal segment via motor neurons. And there's feedback from the muscle spindles of the muscle that's engaging. So what you'll see in treating muscle imbalances is that you have a situation where maybe someone's having knee pain and you suspect the quads are too short and tight, and maybe they've even had surgery and there's inhibition in the quads, so they can't fire as well. And you find that part of that inhibition is being caused by the tight hamstrings. They don't even need to be engaged. Just being short and tight, the signaling from muscle spindles goes to the spinal segment and tells it to shut off the quads because the hamstrings are short, so the body reads that as being engaged. So then naturally the quads need to relax and stretch. But that's not really I mean, that's not necessarily what the person is trying to do. The person is trying to use the quads, and the tight hamstrings are telling the spinal segment to shut off the quads because they need to relax. But you're saying, no, I'm trying to actually go up the stairs and use my quads. So there's an inhibition of the quads due to the tension being read by muscle spindles in the hamstrings. So we need to release the tension on the hamstrings so that the quads fire properly and you don't overuse certain muscles, which will lead to pain. Okay, so the same thing happens with the drop foot, I believe. We need to address, because if the drop foot, it's weak on extension of the ankle. It's weak on lifting the foot, dorsiflexion, extension. Those functions are being weakened, not just by nerve damage. And I'm not saying he doesn't have it. He does. His deep peroneal nerve is definitely damaged by that sciatica flare. However, there is very likely also reciprocal inhibition by the triceps surae muscles. So we need to treat both sides of the leg in this situation. And I think it's just one of the things I was thinking about, and I was thinking about all the ways that reciprocal inhibition could be holding back the progress of my patients, and I'm starting to note to self. I'm seeing people, when I see a lot of people with deep gluteal syndrome, and I'm treating the deep rotators for their sciatica, we're treating the piriformis, we're treating the gemelli, the obturator internus, we're treating the glute max to try to get it firing better. We're treating the gluteus medius because it's super tight and that makes it weak. We want all of these muscles to be able to stabilize the SI joint, the hamstrings, sometimes even adductor magnus gets involved. All of these muscles need to help stabilize the SI joint. And the underlying weakness, the reason that these muscles have overworked, is usually that the gluteus maximus is inhibited. And that's a completely different podcast to talk about gluteal amnesia or muscles, the glutes that always shut off. But, I'm thinking like note to self, when you're in the phase that the patient is now out of pain and they're working on gluteal activation, hopefully with somebody like a physical or physiotherapist, then I can help them more by treating a lot of the tension from the hip flexors. I always think about psoas, and usually for deep gluteal syndrome, the psoas is going to get treated because I also am considering, even like with regular sciatica, that there's some spinal component here, L5S1 compression. Let's consider, or even L4-5 could tighten some of these muscles in the pelvis. So I want to decrease any excess lumbar lordosis. We want normal lumbar lordosis. We don't want excess lumbar lordosis. And part of that can come from the psoas being tight. So I will almost always treat the psoas for somebody with sciatica or lumbar issue, any kind of anything that looks like a lumbar disc compressions, whatever the diagnosis is, treating the psoas is just going to be functionally helpful for taking pressure off of those discs and nerve roots. But then I don't think I always think of it as like, should I, be treating all of the hip flexors? So I will, on someone with deep gluteal syndrome, I will be treating the TFL and the gluteus minimus because they can put internal rotation on the hip, and I don't want the antagonist external rotators to fight against internal rotation. So that would always get treated by me for someone with a sciatica. But I can't say that I always treat the sartorius and the rectus femoris for these people. I probably end up treating the psoas, and I will always treat the TFL and the glute min. And the glute min, I talked about last week how even though it's not a hip flexor, it can increase the anterior pelvic tilt because of the fiber orientation that goes to the front of the hip joint. And then that said, if I'm treating the psoas, I'm probably also relaxing the iliacus, which can also increase the anterior pelvic tilt. So I'm getting a lot of that just by thinking about the lumbar lordosis and the external rotators, and of course the psoas will shut off the glute max. So I'm thinking about that. But now I'm like going through my head and thinking, maybe I need to really think a lot more about something like rectus femoris, because we know when you do we do a length test for the quads, very often you'll see the person's hip come up off the table a bit because of tension in the quad. So just kind of going through in my head, it's not like I've been unsuccessful with patients. In fact, I would say I have a very high success rate for sciatica, but we can always improve, right? We can always improve our treatment. So I'm just starting to kind of think about more about how can I consider reciprocal inhibition and treatment of it to improve the results for my patients. And so one of the things I guess I'm thinking about this week is things like the rectus femoris for these sciatica patients. And then also for the drop foot, I usually end up having to treat the soleus and gastrocs anyway for the same reason. I see that the ankle mobility is not good, but I think it's worth considering more for drop foot. That reciprocal inhibition could be at least some percentage of the inhibition of those muscles on being able to extend the ankle or dorsiflex. So that's what I'm thinking about. That's what I'm doing this week. And of course, if I have great results with this new 90-something-year-old patient, then I will report back about, what we saw and how many visits, etc. I'm hopeful. I think he's going to end up doing really, really well. So that is, I think, enough for this week. Just putting it out there that, reciprocal inhibition is real. And if there's something you've been struggling with a patient, maybe start considering the antagonists that could be inhibiting their strength. You might see that on people whose gluteus medius is not firing, and they're doing all their clamshell exercises, they're doing their bands, they're bridging, etc. Maybe consider looking into how short and tight their adductors are, because even though they're not having groin pain or they're not having symptoms from tight adductors, just the shortening of those muscles could be sending signals to the spinal segment via those muscle spindles in the adductors. It could just be sending white noise, to the spinal segment, telling it to shut off abductors. So it's worth considering if you've been struggling with somebody who can't activate certain muscles. Think about the antagonists that could just be sitting there doing nothing and sending inhibitory signals to the spinal segment and telling it to shut off. Okay, so that's it for this week. Hope you have a good week. Talk to you soon.